We are truly excited for tonight's lecture as we have a very, very special lecturer. On behalf of the Philippine Pediatric Society Incorporated, President Dr. Paul Plaridel Abaya and the officers, technical and organization team, our partners, University of the Philippines College of Dentistry, and our sponsors, Unilab and PharmaHex of Orhex and Densitol. We would like to thank everyone for participating on our final lecture in our String of Pearl webinar series on children with special needs. To welcome us this evening, I would like to call on our very, very hardworking President of the PPDSI for 2019 to 2021, Dr. Paul Plaridel Aguinaldo Abaya Jr.
Thank you, Dr. Mitzi. Good evening, everyone. Let me start by saying that for many of us, this webinar or virtual series of seminars must have been strange to attend to, not to mention technologically challenging. This is the wonder of life. Sometimes it forces us new into directions that are full of uncertainties. This pandemic has certainly pushed us to think about new methods of living our daily lives, and even confronting the new realities of our work situation. But the silver lining is that even with the many challenges it brings, we all have the opportunity to rise above the situation and create our own success. So allow me to congratulate the team of organizers of this four-month-long String of Pearls webinar series. It has been a triumph of teamwork, creativity, and great adaptability. And by all accounts, this webinar series has been a resounding success with a total of 6,000 plus viewers. Through these webinars, we were able to demonstrate the importance of synergistic approach in treating our children, that their medical and dental needs always go together if we are to treat them comprehensively. At the same time, we are also able to learn that treating children is a continuous process from birth up to adolescence. In addition, a pediatric dentist would also know that it is his role to care for his patients with intellectual and developmental disabilities. Part of our responsibility as dental professionals and our moral obligation to society at large is to support inclusive health for the children we treat in order that we are able to reach their maximum potential and have a better quality of life. This has been the battle cry of Bata Muna campaign, and it is my hope that we remain steadfast and united in this cause. Achieving our goal of One Health requires lifelong learning, and this is a key in solving the problems we are confronted with both professionally and personally. So I want to thank everyone for supporting these webinars in pursuit of our goals. I would like to especially mention and thank all the lecturers who have graced these occasions, especially the medical team, headed by Dr. Benjamin Ko, Dr. Angie Sievert, Dr. Emma Lianto, Dr. Miriam Valenzuela, Dr. Francis Di Malanta, and Dr. Jan Harold Sia for their time, effort, and cooperation in making this webinar series a success. Likewise, let me also thank the dental team, headed by Dr. Tess Villarico, Dr. Juan Yepes, Dr. Mitzi Antolin, and Dr. Stephen Perlman for their equal dedication to this project. We have several projects more to go before my term ends, and I hope that I can count on your support for the success of these succeeding projects. Thank you very much. I wish everyone well. Take care and Godspeed. Maraming salamat po. Thanks, Mitzi.
Thank you, Dr. Abaya. I'd like to congratulate you for this wonderful webinar series. If it weren't for you and your team, this wouldn't have happened. And it's truly an honor to have been part of it also. And I would like to thank everybody because even despite the pandemic, it didn't stop us from learning and expanding our knowledge in helping us treat our pediatric patients. We're truly honored today to have our last speaker for the series of the Philippine Pediatric Dental Society Incorporated String of Pearls lecture. We are truly grateful to have him accept this invitation. He is a graduate. He took his postgraduate training program in pediatric dentistry at the Boston University Goldman School of Dental Medicine, and he is the first graduate in the history of the dental school to be recognized as a distinguished alumnus. He is currently a clinical professor in pediatric dentistry in this alma mater. He is a fellow of the Academy of Dentistry for Persons with Disabilities and a fellow of American College of Dentists and diplomate of the American Board of Special Care Dentistry. He was the past president of the Academy of Dentistry for Persons with Disabilities, the Massachusetts Academy of Pediatric Dentistry, and the American Academy of Developmental Medicine and Dentistry. He is a world-renowned dentist, having received numerous awards, which includes Dentist of the Year in 2002 by the American Academy of Pediatric Dentistry Foundation for his significant contributions to the dental profession and the specialty of pediatric dentistry over an entire career of distinguished service. AAPD also granted him many album award and Harold Burke Award from the Academy of Dentistry for Persons of Disabilities. Both awards are the highest honors of the organizations recognizing a lifetime achievement in the care of people with disabilities. In 1993, he founded the Special Olympics Special Smiles, an oral health initiative for the athletes of the Special Olympics International. He currently serves as their senior global clinical advisor. In 2008, in Shanghai, China, Special Olympics honored him with a special Lifetime Global Leadership Award in promoting human dignity. He has published over 300 articles, co-edited the textbook Treating the Dental Patient with a Developmental Disorder, and was contributor to the Surgeon's General Report on Oral Health in 2001. For the past 40 years, he has devoted much of his private practice as well as his teaching to the treatment of children with physical and intellectual disabilities. To my dear colleagues, we are truly honored to have a very, very special lecturer tonight. Let us all welcome Dr. Stephen Perlman.
Thanks, everybody, for the gracious invitation to speak to the Society. It's great to see old friends, old students, and Paul, I'm very grateful for the invitation to present. I wish I could be there in person and see everybody and answer questions and talk about the work, but we'll have to make best with what we've got now. So as a background, I'm a pediatric dentist. Went to dental school at NYU, and after graduating dental school, I had to go into the military for 2 years and served as a Navy dentist, and then went on to pursue my training at Boston University, did my residency at BU, and stayed on as faculty in private practice. And I just retired 2 years ago and from private practice, and still maintaining my teaching and my job at Boston University. So my career path has been very interesting, and I want to share with you where I've gone and the road that I've taken. And the best thing about my presentation to you people today is that I have the ability to work with everybody in the association as the global director of dentistry for Special Olympics. So I was a private practicing pediatric dentist and academic for about 20 years. And I got a call one day, and very active so I'm old school pediatric dentist. When I trained, we took care of patients with special needs throughout their lifetime. There was nobody for us to transition to. We took care of people with disabilities from birth to death. As you know, about 15 years ago, pediatric dentistry became an age-defined specialty. And so the profession no longer takes care of adults. And as bad as access was to care for people with disabilities, it's much worse now, because once we became an age-defined specialty and said to the rest of the dental profession that treating patients with special needs is not our job anymore, they all fall through the crack. And there's virtually no transition anymore from the pediatric world into the general dental world. So what happened to me was, so I was a private practicing pediatric dentist, academic, and did some national work with special care dentistry at that time. And one day, my life changed when I got a call from Eunice Kennedy Shriver. For those of you who are young, President Kennedy, the most famous, glamorous American president that we had, he had a sister with an intellectual disability. Her name was Rosemary Kennedy. And Rosemary Kennedy was, when she was 23 years, so Kennedy family was very prominent. Joe Kennedy was ambassador, the father, the patriarch of the family, was grooming his son to be president of the United States. He was the ambassador to Great Britain. And they had this beautiful daughter, Rosemary, who was, probably had some kind of, yes, there was an intellectual disability, but she had some social issues as well. And in those days, it was an embarrassment if you had a family member with an intellectual disability. So Joe Kennedy, after he became ambassador to UK, moved back to the United States. His son was a rising career in politics and grooming to be the president. Rosemary was an embarrassment to the family. And Joe Kennedy had read about these two doctors, these two physicians at Mass General Hospital, who were doing prefrontal lobotomies on patients with claiming success. And so without telling the family that he was going to have this procedure done to Rosemary, they went ahead and did the lobotomy when she was 23 years old. And it was a total failure. And they turned a vibrant, you could see by the cover of People magazine, what she looked like, they turned a beautiful, functioning woman into basically a complete vegetable by the botched up lobotomy that they did. So now Rosemary was a real embarrassment, and she was banished to a church-run school for the rest of her life in Wisconsin. So basically, how I came into the into the picture was, and there you see a picture of the Kennedy family before Rosemary's lobotomy, the patriarch, the matriarch, President Kennedy, the second one on the left, and Rosemary. And so what happened, they basically turned this beautiful woman into a severely impaired individual. So there's Rosemary when Joe was ambassador to England, and there was Rosemary when I wound up treating her. So the story goes, so Rosemary was getting the best dental care that money could buy. She was seen by a general practice residency at a local hospital. They saw her every 3 months, giving her the best care that she could get. And then one day they decided to edentulate her. And so they needed the permission of the legal guardian, who was Eunice Kennedy Shriver, who you see with Rosemary Kennedy. That was a younger sister. So the legal guardian at that time was Eunice Kennedy Shriver and Senator Ted Kennedy. And when they heard that these dentists were going to edentulate their sister, they said, how could that be possible? There's no way we're going to give permission to do that. And so they put a search on in the country, and they wound up picking me to treat Rosemary. So how odd is that? A pediatric dentist to treat a 63-year-old woman 2,500 miles away. How sad is that situation? So anyway, when Eunice Kennedy Shriver called me and asked me to treat Rosemary, the first thing I did was call her primary care physician and said, was she cleared, because they were going to travel her up to me in Boston to treat her. I had only a one-shot window to take care of her. I had to do an oral rehabilitation under general anesthesia. So I figured the case would take me about 4 or 5 hours to do. The first thing I did was call her primary care physician in Wisconsin to see, one, if she had clearance to do, because she was a physically and mentally impaired 63-year-old woman, if she could tolerate the 5 hours of general anesthesia. Number two, if there's anything else that she needed, because if I couldn't fix the teeth without sedation, then there were other things that needed to be done. So sure enough, the primary care physician asked me if I could if I could arrange for a gynecology exam, because he'd never been able to get one. And then she had some plastic surgery on her face. So they wanted the surgery done. So I arranged, so they flew Rosemary to Boston. I admitted her to the hospital. I restored every tooth, no extractions. I restored everything. And she had the gynecology workup, the plastic surgery on her face. And when I called Mrs. Shriver to tell her sister was fine, was sending her back, she said to me, my family wants to meet you and thank you for everything you did. And more important, if my sister had these problems, what about the poor people in the world with intellectual disabilities? What about them? So the way the Kennedy family works, 2 weeks later, I was sitting in Washington with Eunice Kennedy Shriver, her husband, Sergeant Shriver, who is the biggest American hero, founded the Peace Corps, the Job Corps, Office of Economic Opportunity, ran for vice president, a giant hero in the country. And the medical director of Special Olympics and the founder of developmental pediatrics in the United States, his name was Bob Cook. He was a head of pediatrics at Hopkins and the head of the Kennedy Foundation. And Mrs. Shriver said, okay, you have 2 hours, Steve, to talk to me about oral health and dental health for people with intellectual disabilities. And I said, Mr. Shriver, I don't want to talk about dental health. I want to talk about overall health. And she said to me, what are you talking about? People with ID, intellectual disabilities, get as good or better care than the neurotypical population. And I said, basically, like, what rock are you living under? They get the worst health care. And she said, it's interesting. I thought I'm the champion, the global champion for people with intellectual disabilities. And I thought in order for them to succeed in this world, number one, that they need education and the highest education level they can reach. Number two, job opportunities. What are they going to do when they grow up? Because people need to feel useful in society. Three, where are they going to live with the closure of their institutions? I care about safe housing for them. I never thought about their health. And so I said, Mrs. Shriver, they get the worst health for people with intellectual disabilities. So she looked at me and said, okay, I want you to deliver healthcare for people with intellectual disabilities all over the world for me. And I said, Mrs. Shriver, I have a family, I have a practice, I teach, I have a full boat. I can't do anything like this. But somebody had told me that if you wanted anything from her, if you use Special Olympics as the bully pulpit or the soapbox, that maybe something like that would work. So I asked her for permission if I could work with Special Olympics and use it as a bully pulpit, then I would give it a shot. And so for the first time ever, she allowed somebody to bring in something other than sports into Special Olympics. So I looked at this as an opportunity to enhance the image of dentistry, what I could do for oral health for people all over the world, using Special Olympics as a platform for this. And that's why it's exciting for me to talk to your group today, because we have a strong program in the Philippines and in Asia Pacific region. And I would love to work and further develop the program. And everybody in this audience today can work with us in some capacity to improve the health of these individuals in the Philippines. So basically, what is Special Olympics? An international organization that's year-round sports training and athletic competition. You have to have an underlying diagnosis of an intellectual disability. Don't confuse it with Paralympics. And also just be cognizant, there's only 3 organizations that are allowed to use the word Olympics. It's the Olympics, Special Olympics, and Paralympics. But for participation in Special Olympics, you have to have an underlying diagnosis of an intellectual disability. So basically, Special Olympics has been around. It's just celebrated its 50th anniversary last year. We have 5 million athletes in over 170 countries. And basically, it's to show the world what people with an intellectual disability can do rather than what they can't do. And Special Olympics is all about acceptance. It's not about pity. And basically, I saw this as a platform to change healthcare for people with intellectual disabilities. The power of the organization is amazing. And this picture from sitting in the crowd, so every 4 years we have World Winter Games. Every 4 years we have World Summer Games, just like the other Olympics. And the power of the organization in 2005 was when Nelson, at the opening ceremony for the World Games, when Nelson Mandela came out with Bono, and they sang in the name, in the name of love, and President Clinton was there as well. And so the power of a movement, there's no stopping us with what we can do for people with intellectual disabilities. So basically, we're an unprecedented, a global movement, and now we have unified sports, which brings people, neurotypical people, participating in sports with people with intellectual disabilities. So I created a program. So bringing health into Special Olympics, looking back 27 years ago, it was not an easy task because we were a sports organization. And how did they see, a lot of people, there was some resistance in the movement because it said it would dilute their mission. But basically, if you're not healthy, you can't compete. And at whatever level that you're capable of competing in with. So I started with a dental, and then you'll see how I branched out into other things. But basically, Special Smiles is a global oral health initiative to improve access to care for people with special needs and raise both the public and the dental community's awareness of the oral health problems that people with special needs face. So basically, the goals which I started with have not changed. We've enlarged the program, and we're keep growing and getting into different things. We're getting into women's health. We're getting into obesity. We're getting into sleep. We're doing all these other things. And I could certainly, working with you people, if there's anything that you think that I can improve on, I'd love to have the input. But basically, we conduct dental screenings and educational programs at Special Olympic sporting events. It's to increase the dental profession's awareness of the oral health problems that people with intellectual disabilities face, and to develop a body of knowledge, because nobody knows about the health care of people with intellectual disabilities. It's the most neglected population that there is. We provide lists of dental professionals and schools who take care of them. We have a new initiative called the Community Health Initiative, which we're working with dental schools all over the world and societies. Amazing, amazing things. In India, for example, any Special Olympic athlete gets free dental care in any of the government's almost 400 dental schools. All they have to show is an ID card that they participate in Special Olympics and free dental care in India. We're implementing educational programs, continuing ed for dental schools, working with dental. Every dental school in the United States is involved in the Special Olympic program. We serve as advocates on standards of care and quality of care issues. I'll talk to you about that. We try to, working with our colleagues, our medical colleagues, make sure that our athletes, are they on the right seizure medications? Are they being treated for their constipation? Whatever it is. And we have a sports injury program, injury prevention program, where we provide free mouth guards for the athletes at all the events. And basically, we work with the chief dental officers of the country. I work with the ministers of health, all the dental associations, the dental professions. My corporate sponsors are Colgate globally, Shine globally, working with the very intimately working with the CDC because they're using my data, as well as the World Health Organizations and other organizations. So basically, I'm going to first part of this lecture is we're going to talk about the Special Olympics and how we can work together. And the second part, I'll get into some of the treatment that Paul asked me to delve into. So basically, we have a pre-event continuing education. We register the athletes. They get one-on-one oral hygiene instruction. We do our screening protocol, and then we have interactive nutrition, And we give everybody a goodie bag with a toothbrush, toothpaste, and everything else. So basically, when I started the program, I developed my own screening program. And 2 years later, the CDC, probably the world's premier health organization, the Centers for Disease Control, called me and they said, Steve, we really need to work with you because we know how many births there are basically in each country, how many births there are with Down syndrome or maybe spina bifida, but we don't know how the disability affects the quality of that person's life. Or for children with autism now, the latest autism data in the United States, 1 out of 54 children are born with autism now in the United States, 4 times as many boys as girls. So the CDC came in and they said, we want to develop your screening protocol. And so we're going to make all of your dental screeners a public health dentist for the day, and they're only going to look at what we want them to look for. So the data that I'm going to present to you tonight is standardized. Every screener has to be calibrated before they come and screen for us. And so everybody can use the data. So this is what the day looks like before the Special Olympic event where the athletes come to participate in the sports. We're going to do multiple health screenings on them. So we gather all the volunteers together. They've studied the screening protocol. Maybe they do it the morning of, maybe they do it before at the university. We do a lot of work with students, but everybody who's trained to screen is trained in the screening program. We register the athletes. We're doing everything on computers now. We register the athletes to get their information. We do the intraoral screening according to the CDC protocol, which is non-invasive. We do a thorough head neck examination on them. From the dental screening, they get one-on-one hygiene instruction. And you could see from the slide with the hygienist showing the athlete how to brush. For many of the students, we work with a tremendous amount of dental hygiene students and dental students, dental assistants. This Special Olympic event may be the first time for their exposure to a patient with special needs. We have nutrition. Sometimes we do height and weight. We do smoking. We do obesity. We're looking into waist-height ratios now. We're getting into sleep. We're getting into women's health. We're doing all these other things. The program, it just keeps growing and growing and growing. And so there's a picture of the mouth guard program. We use the best boil and bite mouth guard that's made. We have a new mouth guard that we're using this year, which is fabulous. So every athlete that competes in contact sports gets a mouth guard. And then we put on fluoride varnish. And then the athlete gets the goodie bag to go home with. And so for many healthcare professionals, it's the most rewarding day, and they've reported to me and come back year after year to volunteer that it would be the most rewarding day that they've had in their professional career. So today, Special Olympics is in 175 countries, athletes. We have over 71,000 competitions a year, and probably now about 1.5 million volunteers for the organization. So from the dentistry, I went into vision, we went into hearing, we went into physical therapy. We do health promotion, such as sunscreens, healthy eating. We have a MedFest program where we do the physicals so the athletes compete, the dental program, which I talked to you about, and a foot program where we provide sneakers sometimes, and we good foot health for the athletes. So I wanted to share with you the data that we've collected. So you can see that from the ages of 2 to 19 years old, look at the data from the Philippines. Of course, this is a very small, where we're looking at global 2 to 19. We have 125,000 screenings in the Philippines at this time. We only had 138, but look at the burden of disease. 20% of the athletes showed up at the time of the competition in pain. Almost 90% of them had untreated tooth decay. 45 had missing teeth. Anyway, a huge burden of decay. And I just threw the vision, a lot more vision, almost 2,000 athletes in the Philippines had the vision program. But look at that, almost 1,000, 50% of those athletes never had an eye exam. A third, look at the number, 361 had eye disease, and almost a half of them needed new glasses, a new prescription for glasses, which means that the vision specialist, whether it be an ophthalmologist or an optometrist, did a quick and dirty exam, looking at a very small sample size of adults. Same thing, 20 out of 90 had presented at the event in pain. It's unconscionable. Needed urgent, almost 1/3 of the athletes needed to see a dentist immediately. And the vision data on 501 athletes over the age of 20 is horrific too. So there's a huge burden of disease that we're looking at, and just the tip of the iceberg in the Philippines. Because if somebody's participating in Special Olympics, that means there's somebody in their life that loves them, that's paying attention to them, and that brings them to the competition. These aren't people that are just sitting neglected in a group home or anything. And I know this chart is hard to read, but I just wanted to show you that what we're doing is we're collecting data so we can link height, weight, obesity, poor vision, tobacco. We can look at everything. And so you see in the Asian Pacific, I have data on 26,000 athletes. So in Asia Pacific, 26,000 athletes, and 4,000, 17% of them presented, 17% of them presented in pain at the, and needed urgent referrals. 5% needed urgent referrals. So the burden of disease in this population is huge, but we really know it. So what did I do, and how did I take this program into being the world's premier? It is the #1 health program for people with intellectual disabilities today. So the first thing that we did was I had to show that this population was underserved. So when we started out on this journey in the year 2000, the first thing we did was we thought the most respected public health program in the world was Yale Medical School. And we went to Yale and we got the health status and needs for individuals with mental retardation. And that should have been a volume. It was nothing. It was like 120 pages, which showed that we knew nothing about this population. We took this document, and only the Kennedy family could have done this. We took this document and went to the United States Senate and had the first ever Senate hearing on health disparities for people with intellectual disabilities. And that was amazing. That happened at the Special Olympic World Winter Games in Anchorage, Alaska in 2001. And at that meeting and at that Senate hearing, I had the opportunity to talk one-on-one with Surgeon General David Satcher, and he agreed to have the first ever in the history of the United States, the first ever Surgeon General's Conference on Health Disparities and for people with mental retardation in 2001. And at that conference, that became the next turning point in my career and the turning point in healthcare for people with intellectual disabilities, because it was about 250 people. It was like the who's who, maternal and child care, Center for Birth Defects, CDC, NIH, NIDCR, all the government agencies were there. And basically, at the end of the conference, I started to get calls from physicians all over the United States. It's like, Steve, I met you. I'm a neurologist and I'm an expert in seizures. I want to work on your team. I'm an anesthesiologist and I'm an expert in craniofacial deformities. I want to work on your team. I'm a gastroenterologist and I scope all the people with intellectual disabilities in my huge group practice. I want to work with you. And so we formed the American Academy of Developmental Medicine and Dentistry. And I encourage everybody to join this group if you have an interest in special needs, because it's an amazing organization. It's half physicians, half dentists, everybody on an equal status. But how I've been able to move the bar for healthcare for people with intellectual disabilities, it's working with physicians in collaboration. And then I want to go over some of the things that we've been doing. I have collaborative agreements with different organizations. And I want to just briefly talk about some of the accomplishments that we've been able to do. So #1, the biggest barrier that I had in the United States in getting access to care for people with intellectual disabilities was the way the dental profession, people with ID tend to be on Medicaid. Dental schools are not educating the students in the care of patients with special needs. And all these years that I've been working, all I heard from parents and caregivers was I tried to make an appointment in an office and I couldn't get, and the dentist said that he wasn't trained to treat patients with special needs. He didn't want to treat patients with special needs, whatever it was. So I've heard this for year and year, and I've never been able to move the bar. But finally, the National Council on Disability hooked up with me, and we went after the dental profession. And so what we did was we actually changed. We went after the dental profession for violating the Americans with Disabilities Act, that people with ID did not have access to dental offices. And so we petitioned them, and we actually won. And the ADA actually changed the code of ethics of the dental profession. So whereas the dental profession code of ethics said that a dentist could not refuse to treat a patient because of age, because of gender, because of color, because of sexual orientation, whatever it was, the word disability was not in there. So that was the escape. When parents called up and caregivers, oh, I never got the training, I don't want to do it, whatever it is. But now we inserted the word disability in the code of ethics of the dental profession. And so a dentist now is obligated to be able to treat a patient with disability. He may not have the level of skill. It's not an indictment of dentists that they have to treat somebody. They may not have the skill level based on the person's disability. But the issue is now that they can't just say, I'm not going to treat that patient. I'm not going to treat your son. I'm not going to treat your daughter. Now the obligation is if you can't do it, then you have to find somebody who will do it for you. So right now, that word, disability, is in the Code of Ethics of the ADA. And so we have changed the landscape for the profession. That was strictly Special Olympics working with the Academy of Developmental Medicine and Dentistry that did this. It's 100% of the credit deserved for us. Now, it's interesting that this was passed, and then look at this editorial in JADA. Can you believe that the ADA responded by the ethical dilemma of treating or not treating patients with intellectual? Could anybody ever publish anything like this? The ethical dilemma of treating somebody who's Black or somebody who's gay or somebody who's Jewish? I mean, it's unbelievable that they would print this, but it shows where the profession, they still can't get it about people with intellectual disabilities. So basically, and we're going to define here, this is what we define patients with special needs as, those who are, and it's a pretty broad definition, but we wanted it broad to include everybody that we could to enlarge the scope of access to care. Okay, so that was the first thing that we did. Now that we changed the code of ethics of the dental profession, now the Council on Dental Accreditation has to cave in too, and they did. So now, because it's in the code of ethics, now the dental schools, before we were working with the most watered down. So it was Special Olympics that approached CODA 25 years ago. We approached CODA, Council on Dental Accreditation. There was nothing in CODA that dental schools had to train dentists to treat people with intellectual disabilities and physical disabilities. Nothing in the council. So we fought them, and the only thing, CODA did change the regulation, and they inserted something 20 years ago, but it was that a dental student and a hygiene student only had to be proficient in diagnosis and treatment planning. There was nothing to do about treatment. They would not put treatment, and when we fought them on it, they would not give in because they said, number one, the dental schools can't make any money on this, and number two, they don't have the faculty to teach it. So we had the most watered down regulation that they could be. But now that the word disability is inserted in the code of ethics of the dental profession, now council, and last year in 2019, CODA passed that dental schools are now obligated not only diagnosis and treatment, but actual treatment in patients with intellectual disabilities. So what do we do now? Wherever I'm stating with public policy and position papers, and I'll be happy to discuss these with anybody. If you go to the AADMD website, aadmd.org, you can see that we've got great public policy position papers on teaching students developmental medicine, declaring people. So right now in the United States, if you're a medically underserved population, is if you're African-American, Hispanic, or Native American living in a zip code, you can be medically underserved. And that's got huge ramifications: loan repayment for students, money for studies, research, everything. Right now, people with intellectual disabilities are not medically underserved by the federal government. Even though the AMA passed it, the American Dental Association, the federal government hasn't changed that status. We're working on a curriculum with medical schools. We have a task force on aging and dementia. You know that people with Down syndrome, virtually 100% of them get Alzheimer's after the age of 40. We changed the regulation of the vitamin D intake, the rules, not the rules, but the government, at the FDA approval for how much vitamin D supplements people should have doesn't work for people with ID, especially those with seizures, because seizure medication negates vitamin D absorption. So we actually changed the vitamin D requirements for people with intellectual disabilities. And then we've tackled other cases, and I want to talk to you about some of the cases that we've tackled and how we've changed the landscape for healthcare for people with disabilities and intellectual disabilities. So this is Amelia, who's a 3-year-old little girl with a Wolff-Hirschhorn disease. Her parents are both school teachers in Philadelphia. They live in New Jersey. And Amelia was given a diagnosis of 6 months of a year to live because of kidney failure, because of the Wolff-Hirschhorn disease. So Amelia was recommended for a kidney transplant by her physicians. She had an appointment at Children's Hospital in Philadelphia to get the kidney transplant. She met with the surgical team, and she was going to meet with the surgical team, the mother, and the mother was the kidney donor to Amelia. The mother was the kidney donor. Amelia, the parents went to meet the head of the transplant team. They walked into CHOP, #1 children's hospital in the United States. And the head of the transplant team looked at them and said, yes, Amelia needs a kidney to live, but we're not wasting the time of our transplant team on a child with an intellectual disability. They actually said that to the parents. The parents walked out in a shock. They went on a blog. They said, who in the country can help us? And somebody emailed me immediately and said, Steve, what are you going to do about this? I mobilized my ADMD troops, and we sent a letter. Within 4 days, I had my physicians on the team research organ transplantations in children. This is a copy of the letter that we sent to Children's Hospital. And I just want to read that this is the opinion at the end that the board of the American Academy of Developmental Medicine and Dentistry, that transplant centers begin to embrace the idea that more than organs are being transplanted. What is hopefully being transplanted is the notion of dignity, justice, and humanity, the very triumvirate philosophy that we hope will continue. So basically, the great news on this was Children's Hospital rescinded. I mean, we were the only group that came to this parent's defense. And so Amelia, that's a picture of me with Amelia's mother. She brought Amelia to our meeting the next year to show us that her daughter was, to just present her daughter to the group and thank us for saving her life. And it really got to me that she went on this blog 2 years later that instead of visiting, if it was not for us, the mother would be visiting her daughter's grave, but the ADMD came through and got the kidney transplant for her. And as a result of that, there's a law that was passed in New Jersey and other states that a child could not be denied an organ transplant because of the level of her intellectual disability. Another case that ADMD fought through Special Olympics was the Sarah Mernigan, who she had cystic fibrosis. She's a 12-year-old girl. but she wasn't 12 yet, and you need to be 12 to get an adult. You have to be over 12 to get an adult lung. Lungs are hard to get, pediatric lungs, and because she was shy of 12 years old, the government was not allowing her to have her life saved by having a lung transplant. We fought that case, and we got Sarah her lung, and she's thriving now. I'm working on a project in East and Central Africa. Do you know infant oral mutilation? I got a call from the chief health officer, chief dental officer of the United Kingdom to help them out on a project. Infant oral mutilation is the gouging out of primary cuspid tooth buds on children that are 4 to 20 months of age. Tens of thousands of children are dying each year as a result of infant oral mutilation that's taking place in Africa. The kids with special needs, we don't have breakdown in numbers. We just know how many children are passing away from this. But we know that it's a much higher ratio in children's with this special needs because they're so much more susceptible to disease. The primary tooth buds are gouged out by, they look like tooth worms. Children in East and Central Africa die of infection and diarrhea and malnutrition. And so tribal healers, which is the most form of medicine is delivered by tribal healers. There aren't a lot of trained physicians in these areas. And so they gouge out these primary tooth buds by rusty nails, bicycle spokes, razor blades, and these children get severe post-op infections and wind up dying. So we're working on a project to end infant oral mutilation in Africa. There's the policy statement by the AADMD on that. And so, and here at a training program that I ran in Africa, the woman is the chief of pediatric dentistry and runs a special care clinic at the University of Pretoria. And she came to volunteer at the Special Olympic event, and I've trained her to work throughout Africa in working with volunteers for Special Olympics. And she told me the story. That's her son Thapelo with her. And when Thapelo was born 4 years ago, or actually he's 9 now, but when this picture was taken, when Thapelo was born, Kathy gave birth. It was her 4th child. She had just given birth in South Africa, and she was waiting to hold her baby. She was still groggy from the anesthesia. And a physician brought her baby over to her and held his face over her and tapped his feet and said that your baby has all the characteristics of Down syndrome. Do you want me to end his life now, or do you want to take him home? And if you take him home, then there's a high incidence of divorce. He's going to be a burden on you for the rest of your life. If you want, we can terminate his life now. And as groggy as she was, she said no. And that's her with her son. And you see that her comment is, I thought I would have to teach my child about the world, but it turns out I have to teach the world about my child. And her son, who the physician wanted to end his life now, is the apple of her eye. And he's thriving and doing so well. And can you believe that this attitude of physicians still prevails as recently as this? This picture was taken. This is a Special Olympic athlete who participated in the World Games in Abu Dhabi a year ago. And he came for his dental screening, and the dentist brought me over, and they said, we're concerned about his eyesight, we're concerned about his breathing. We don't know if that's a growing tumor or not. And so at least we brought him over for different consults. And the story about him is so tragic. When he was 11 years old, the principal of his school, he's from Rwanda, and the principal of his school brought his parents in one day, and they said, your son can't come to school anymore. He doesn't even look like a human being. He's too much of a distraction for the other students. Please, you're going to have to homeschool him for the remainder of his education. We don't want him in school anymore. And so he was basically lived in isolation with his parents until somebody from Special Olympics found him. And he now made it turns out he's an amazing soccer player, and he made the Rwandan, he's the captain of the Rwandan soccer team. But when he went through the screening, we realized that he had more health problems, and that if he went back to Rwanda, the decrease in his respiratory system was and the ocular system wasn't working. So we actually convinced the Emirates government they're going to pay for his corrective surgery. The Emirates flew his parents with him, and he's now living hosted by Special Olympic family, and he's now going to have his corrective surgery done for free by the Emirates government. So these are the amazing stories that, and I could tell 100 more different stories, but I just want you to realize that the Special Olympics program, it's more than a dental screening program. It can be life-changing, and we've enlarged it to become the best advocacy program. And I want you to realize that even in your practice, you must become an advocate for your patients with special healthcare needs. So Gracie is a patient of mine in my practice. When she was born, she had to have the corrective heart surgery, the tetralogy, and because of the surgery, she developed a postoperative infection. One leg never grew because of infection. One leg never grew as long as the other leg, and so she had to walk with a walker and an appliance. And as she grew, you could see that Gracie has Down syndrome. She's legally blind, and she's G-tube fed. And she goes to Children's Hospital Boston. Great Children's Hospital, sees the head of orthopedics. And the time this picture was taken, the head of orthopedics said to the parents, okay, now Gracie's going to have a problem walking for the rest of her life. We're going to amputate the leg and make a prosthesis, and that's how she's going to grow. And the parents said, you know, what are you talking about? She's legally blind. She's got Down syndrome. She's G-tube. We can't do this. The physician said, I'm the world's expert on this. I'm saying that we have to amputate the leg and make a prosthesis. Poor parents went for a second opinion at Johns Hopkins, and the physician there said, yes, I agree with the doctor in Boston. This is the only way that we can treat her. The parents came back to me and said, can you help? What do? We don't want to amputate her leg. And through my contacts in AEDMD, we found a surgeon in Florida who took one look at her and didn't look at Down syndrome, didn't look at all the other problems she had, and just said, I can fix that leg. And so they went down to Florida. She had the surgery, and now Gracie is fine and walking. So you have to become the advocate. And as you all know what I'm talking about, the arrogance of some physicians and the way they handle families is so horrific. So, and the parents can't even talk about this because they came so close, be bullied by the physician to amputating a daughter's leg when there was somebody that looked beyond that disability and said, yes, I can fix that problem. My practice when I started out, it was roughly 23% Medicaid. I have a partner, my whole career, one of my classmates was my partner. We trained together in pediatric dentistry, and then he did 2 more years as an orthodontist. So we practiced pedo and ortho. Our practice was limited to dentistry for children, adolescents, and people with disabilities. So one day this gentleman, Richard, comes into my practice. So Richard was misdiagnosed medically and had gangrene in his arms and legs and wound up having to have all 4 limbs amputated. And he came to my office as a pediatric dentist, and I said, he asked me if I would treat him as a new patient. I said, you can go to any dental office. Why are you coming to a pediatric dentist? And he said to me, nobody in dentistry wants to treat me. They don't want me sitting in the waiting room. I'm wearing shorts. It was summertime. I don't have any arms and legs. They just didn't want me. So he wound up being a patient of mine. And I loved it. He was a great patient. And then I took care of him for many years. And he came to me and he said, Steve, I'm going to be the first human being to get a bilateral arm transplant, hand transplant. I said, are you kidding? And so a couple of years ago, he became the first person to get bilateral, and his hands are working fine. It's amazing. And if I didn't treat him, and if I didn't treat patients with disabilities in the adults, I started to say before I got interrupted, I saw my practice go from about 23%. When I retired, we had 1,200 patients with disabilities in our practice, both children and adults. So anyway, my life has been richer by treating these patients with disabilities. So I want to talk a little, now let's get into the barriers to care for this population. You know, it's always been when people ask me, Steve, why don't dentists treat patients with disabilities? And what are the barriers? Well, it's degree of dependence on others. You know, finances, who's going to pay for it? Most of them are at the poverty level and they can't afford it and they're on public assistance programs. The attitude of the care provider. You know, a lot of this population that live in group homes, they're taken care of by direct support personnel who don't take care of their own health, let alone taking care of somebody else. The availability of professional care in Massachusetts, other than pediatric dentists, oral surgeons, and some general dentists, there's nobody that will treat patients with special needs. Very few, if any, endodontists, periodontists, and prosthodontists. They just don't treat these patients. And then, of course, they handicap access to an office. And then a new barrier to care is this fear of accusation. You know, we'll talk a little about immobilization and stuff. But the dentists are afraid to treat patients with special needs because of they don't want to be criticized for if they have to hold somebody's hands down while they give them local anesthesia, or the micromanaging from the social model people. And now another thing is this parenting. You know, modern parenting is a huge problem. I was looking at the pediatric chat line from the American Academy the other day, and they're now talking about sedating children for crying, because the minute they cry, the parents want to put them under general anesthesia. So, you know, modern parenting is taking a huge toll on parents. You know, I've always had to deal with the helicopter moms, you know, the hoverers, the snowplow moms that, you know, that push everything out of the way, the tiger parents. But now we're faced with dolphin parents, jellyfish parents, elephant parents, gardener parents, and carpenter parents. This modern parenting is just awful on and creating their own barrier to care. I thought this was just cute, raising a child in 1982 and raising a child today. And this is where it's happening. You know, parenting has just changed so much. It's interesting looking at techniques, behavior guidance techniques when I trained and throughout my first 20 years, you know, from going into hand over mouth as an exercise. And now it's the least, now they want their children put under general anesthesia. I'm talking about neurotypical kids before anything else. So modern parenting, but stigma for patients with special health care needs. It's the stigma. This population is looked at as they're low reward, limited respect. I've been told, oh, you take care of people with special needs because you're not good enough to be a cosmetic dentist. You know, instead of you take care of that kid that's like a pogo stick in the waiting room with autism that's moving his head around and everything else. But it's the stigma. I've even told, I had a conversation before I retired with somebody who is the state of Massachusetts, one of the people in developmental disabilities in the federal government. She actually told me that, you know, people with Down syndrome, they don't feel pain, so you don't have to give them local anesthesia. I mean, I can't believe the things that people have said to me over the years. But stigma, you know, oh, you're treating that population because you're not good enough to do real dentistry. Communication problems, you know, everybody's busy in their office, and communication is a problem. Look at the eye physicians. Ophthalmologists who get a patient, they can't read the eye chart, they can't follow directions. How do you give them a pair of glasses? You know, oftentimes communication, nonverbal patients that we see. How many times have we all been brought patients who have been having they're self-abusing themselves or something, and the parents or the group home says there's something wrong with them, but they can't communicate it. And the person who brings them to your office may not be the person who was with them all the time, so they can't even help you come up with a diagnosis. You know, we're relying on direct support professionals to take care of them. The patients, group homes, community residents have over a 70% turnover in employment during the year. You know, we spend time going over oral hygiene, we spend time going over the needs of the patient, and then the person who's with them the next time is somebody else because of the turnover. It's a low-paying job. It's not very rewarding to change the diaper on a 40-year-old adult. You know, follow-up care, the problem with record keeping, with seizures, with bowel movements, with menstrual cycles, the follow-up on people and getting information is very inadequate for us, and to help the patient follow through whatever problems they have. Reimbursement levels and changes, the staff changes, the same thing with the community continuity of care for these people. You know, total lack of transition. In every, I mean, I work with pediatric neurologists, pediatric endocrinologists, pediatric cardiologists. The transition from those groups is impossible to the adult world. The pediatric neurologists see totally different problems than the adult neurologists. The adult neurologists don't know how to handle the kids who have pediatric cardiac syndromes. The transition from the family to the group home. Social role valorization. You see that the low society, many societies, many healthcare professionals think that people with intellectual disabilities, they're not educable, they're not contributory to science, to the social, to society. They have very little regard for them, and it's like we're gonna have to pay for these people for the rest of their life. So very poor look at the way people look at people with intellectual disabilities and their contribution to society. What is the value of health and wellness? I can't tell you the stories I've heard over the years. The parents who wait 3 months to see a specialist because their daughter is writhing in pain from a period, and they finally get the appointment with the top specialist, and the guy looks at them and just says, well, why bother? Why bother? It's my daughter that's writhing in pain every time she has a period. Help me. We know that she has an intellectual disability. We're not here for that. We're here for you to cure her gynecological problems. But that's the way many healthcare professionals look at, they just look at the person and not the problem, and can't appreciate why the parent is bringing, or the caretaker is bringing to them. The culture of an institution. You know, look at the dental schools all over the world. The dental schools in the United States that have pediatric dentists as deans, that have humanitarians as dean, as opposed to deans. So a dean can have, it can be high on his priority list to train his students to be good clinicians in patients with special needs. And some schools have virtually no experience for their students. So it's the culture of an institution that's a big barrier. Regulations, crazy regulations. We just had a fight in Tennessee. Sunblock could only be applied in the law of Tennessee. Sunblock could only be applied by a nurse or a physician. And so nobody was going out on the weekends because nobody wanted to pay. The agencies would not pay nurse salaries or physicians to do it. So nobody was getting sunblock on the weekends. Nobody was going out. It took us years to fight for the state to allow direct support personnel to put on sunblocks. So crazy, archaic regulations that are no longer, and it's accountability. And this is a huge problem for us for patients with special needs. And here's a case that was in my practice. That's a perfect example of the problems with accountability. So this young woman is 20 years old. She's a victim of abusive head trauma. When she was 2 years old, she was normal. And when she was 2 years old, the mother's boyfriend slammed her head against the wall repeatedly. He severed both optic nerves. So she was placed in foster care system, and now she's 19 years old, and the foster parent gave her up to the state and said, okay, you take care of her. So a group home, she was taken into a group home and came into my office, and she's totally blind. She's in a vegetative coma state. And the first thing, and she never had any dental care. So she had great needs. I had to do her in the operating room. The first call I made was to the physician. And he said, yes, can you do a gynecology exam so I can make sure she's not been sexually abused? And can you get an ophthalmologist to look at her optic nerves to make sure that she's legally blind? And so I arranged for the oral rehabilitation. I booked the hospital operating room for 4 or 5 hours, got an ophthalmologist to come in with me because they can actually flip the eyeball out and look at the optic nerve directly. And I got a gynecologist to come in and do the exam. And I needed the legal guardian. There was no legal guardian. We had to wait for the court-appointed legal guardian. The thing is that to get the case in the operating room, I had to have a DNR order removed. And so we called, so I booked the case, booked the ophthalmologist, the guy, everybody's coming to help me do this case. We had 5 weeks of warning. We called the group home and said, okay, you got to get a judge to remove the order. We called the group home. They called the social worker. Social worker turns it over to the legal system. Every day, the last week, we called, did you get the order removed? Did you get the order removed? And at the last day, at 4 o'clock, the day before I just do the case, can't get a probate judge to remove the court order. You have to cancel the case. Cancel the case. I said, I can't do it for months and stuff like that. But it's like, so here's the issues. Who's got the responsibility? And with many patients with special needs, the buck just gets passed from one person to another person to another person. And that's a huge barrier to care. And who is actually the responsible party? Who is the legal guardian? These things come up all the time. And then the changing face of healthcare. Now, when you're in a hospital, your physician, your primary care physician does not take care of you anymore. It's a hospitalist that's going to take care of you. Hospitalists get very, very poor training in patients with special needs. So what's happening is patients are spending way more time in the hospital than they need to be, or they're getting discharged way before they need to be discharged because of the lack of experience in the hospitalists in training them. So, okay, now what are we know that dentistry is the most unmet healthcare need for patients with special needs. In the largest study ever done by the government, almost 40,000 families of special needs children were interviewed. We know that dentistry is the most unmet healthcare need for children with special healthcare needs. We know that roughly 80% of these kids are going to need care in the last 12 months. It's second only to prescription medication for the frequency of need. What we do know is that children that are poor, children that are insured, underinsured, or lack of insurance in between, they go on and off Medicaid or whatever it is. And we definitely know that the greater the disability is of the child, the more difficult it is for them to obtain a dentist to be able to treat them. And we know that children without a dental and a medical home are less likely to get care. What's the burden of disease in this population? Probably, again, the largest study ever done. Tufts Facility for the Handicapped in Massachusetts is one of the premier programs in the country. It's a contract that the state has with Tufts University. They have many outreach dental clinics for this population. And so what the Tufts program told us, in their studies, what increased the risk of significant oral disease in this population. It's what we know. It's the medications. It's the social determinants of health that we all know of, including poverty. We know that the older the person is, the more difficult it is for them. Children get taken care of, but as they hit the cliff of 18 or 21, it becomes a huge problem, whether they live with their parents or they live in a group home or aggregated community setting, whether or not they have insurance or Medicaid. And again, the area where they're in, the scarcity of trained dentists that will treat them or not. So the results of the Tufts study has shown that, look, in a controlled group with dentists that are trained to treat special needs, patients with special needs, look at that. A third of them had untreated decay. 80 people that go into the dentist all the time, over 80% of them had periodontal disease. And what I don't get is that the 25% of the patients had only 20% could have been treated without advanced behavioral techniques. And a third of them had to have a general anesthesia or sedation. It's just overwhelming burden of disease in this. So even with a specialized dental program, this population has a very high burden of disease, which we know it. So too many times in dental school and dentists in practice, they're only focused on teeth and gums. That's it. But those of us in the world of special needs know that we have to look at the whole orofacial complex, because our patients have difficulty breathing. When we work on them, they may have difficulty breathing. They have problems with nutrition. They have problems because of neuromuscular disease. They have problems with the communication. The kids with autism are hyper and hyposensitive. We know that they're neurologically impaired. We know that they might have swallowing problems. They may drool. They exhibit bruxism. So we have to look at the whole orofacial complex to understand and better treat our patients. So in the words of Martin Luther King, of all the forms of inequality, injustice in healthcare is the most shocking and the most humane. And the other quotes that I think I just wanted to talk about, because when I get into medical mobilization, is Sir William Osler, who's the doyen of modern medicine, told us that we should do the kindest thing and do it first on our patients. And in Mark Twain, do the right thing. It will gratify some people and astonish the rest. And I think that in Francis Peabody, this is how I tried to practice my whole career. And I think I impart this on the students that I teach, that the secret in caring of the patient is really caring about the patient and for the patient. And then another thing that's really important for us is that, and this is certainly so apropos, that people will forget what you said to them and what you did, but they will never forget how you made them feel. And countless times when you have that parent that says to you, that's got difficult behavioral issues and things, and the parents say, gee, can my son have braces or my daughter have braces? And in your heart, you know it's never going to work. But how you answer them and the expression you have on the face when you want to say, like, are you kidding? I'm lucky I can get anything done on them. But they'll always remember how you feel. And that's a real tough thing. But trust me that this is one of the most important things in being successful in your career, is how you make them feel. So I want to end this with the talking about treatment, because this is always the elephant in the room. And maybe I'm old school. I trained in in sedation, but I went to a program that was really behavioral program. And so I can honestly, in the last 15 years of practice, I never did a child in the operating room. I was able to handle all children. And how many times I told you, with 1,200 patients with special needs, I probably went to the operating room 20 times a year. And that was with interdisciplinary care when they needed, I would get the call when I have to do a scope where you have to look into their ears, will you do their teeth at the same time? So and certainly this is very interesting because it's very apropos now with the COVID situation in the world. I've been following the Academy of Pediatric Dentistry on the chat lines. It's like they're not getting, none of the pediatric dentists in the States are getting operating room time anymore, because there's been such a backlog in the medical side that all operating room time is given to physicians. So pediatric dentists are not getting operating room time. And they're all crying that they can't, use the operating room. Well, you know what? There are other ways to treat the patient. And instead of crying about not getting the right to use it, everybody should start thinking about how they're going to take care of these patients in this COVID era. So basically, I don't want to get on the soapbox, but certainly when I'm available to answer any of the questions, we'll certainly tackle them. So basically, I always looked at the patient as how am I going to treat them Am I going to treat them normally with or without medical immobilization? Am I going to pre-medicate or sedate them, or ultimately bring them in the operating room under general anesthesia? So basically, behavioral guidance. We got rid of the term behavior management. That's what my generation used. Now we only use, nobody likes to manage behavior. So we're going to guide behavior, and it's a continuum of individualized interaction. And so it's between the dentist, the parent, the family, and it's basically to build the trust and allay the fear and anxiety of the patients. And so we become a role of teacher. And so our job is to get the patient to accept dentistry in the way it can be delivered. And we can practice painless dentistry today. And so this is a technique, anybody's welcome to this. In my practice, this is before I treated a patient, the family or the group home, somebody had to sign this document, and it lists about the patient, the behavior guidance that I'm going to use on your child. I may start with tell, show, do. I may raise my voice. I may give positive reinforcement. I may have to use a mouth prop or immobilization, whatever it is. The parent had to sign. And if they had an issue with it, you could see it's my philosophy in treating children and patients with special needs. It's based on how I would want somebody to treat my own children or my grandchildren. And then if I was going to use medical immobilization, there was a separate form that I had the parents or caregivers fill out, and it demonstrated, and it certainly talked to. So, behavior guidance, there are look, there are so many different ways of behavior guidance, from voice control and nonverbal communication. I practice in an open bay with my partner. Two of us work with 4 chairs. TVs were I used nitrous oxide. I found that TVs were just as good of an escape for children. So we had TVs. A friend of mine who evaluates a dentist who goes into offices recently, when she called me to tell me for an insurance company, she went into a dentist's office and picked 60 random charts in a pediatric dental office. And all 60 patients had nitrous oxide. Every patient got nitrous oxide. And half of them never even had a consent form. The parents didn't even know that they were doing it. So certainly these things are a controversial issue and abuse. So, those are the behavior guidance techniques that you can get. Any textbook on pediatric dentistry have that. Offices, especially with these kids, 1 out of 54 with autism now, aromatherapy, dental offices smell, sensory integration, Castillo Morales with his touch and pressure, music therapy, and equine. I have friends that if they could get a horse into their office for equine therapy, they would do it. So basically, and I'm convinced, like I showed you the original barriers to care, and it's money, and it's, but I'm convinced, and certainly the literature can support it, that the reason why dentists don't want patients with special needs in their practice, it's the behavioral issue. It's the behavior. They don't want the kids screaming. They don't want in their offices to sound like Halloween and Fright Night. That basically, that you can give more money to dentists, and there's still, people use that excuse. It's interesting, in Massachusetts, years ago, I'm talking about neurotypical children. So basically, they raised the Medicaid. The state of Massachusetts was being sued by parents because there weren't enough dentists that were treating Medicaid patients. Those are patients that are poor, need federal assistance. So they raised the fees 38% for all pediatric dental services overnight. They raised the fee 38%, and guess what? No additional providers wanted to service that population. It couldn't get any other additional population. So I'm convinced that it's the behavior rather than anything else that's a barrier to care. So basically, we're always going to start from the basic tell, show, do, least restrictive behavioral guidance technique, always. And think about this. Really think about this statement that clinical dental treatment is the most exacting and demanding medical procedure that a person with a developmental disability will undergo on a regular basis through their lifetime. Dental treatment is surgical in nature, requiring controlled placement of sharp instrumentation around the face with an airway and highly vascularized and innovative nerve tissue. We are working with a high-speed drill on the face. Excuse me. What surgeon would operate on a field without complete control of that field? So how can we, as dental clinicians, expect to do equal quality of care on somebody, a moving target, for example? So how we need to have control of that situation. So I'm Larry, the cable guy, and I'm just going to get the job done. So basically, little girls, they've always held their dolls close to them. If you love somebody, you swaddle them, you hold them close to you. In history, Native Americans in the United States used papoose for their children. Surgery during the Civil War, immobilization. Again, universal, all over the world. Children, the people, the little dolls that they love, hold them close, immobilize them, hold them close to us. Boys with their G.I. Joe, girls with their Barbies or whatever it is. Look at the original logo from the American Academy of Pediatrics. It's a child swaddled. When you take a baby home from the hospital today, they're swaddled. Okay? So I never use the word restraint. We've gotten rid of the word of restraint. But there is nothing wrong with, if we need to provide care and we need to provide equal quality of care, there's nothing wrong with medical, so no more restraint. We medically immobilize, we protective stabilize somebody so that we can do this. This did not come from me. It came from New York State, where there was an incident and there was an incident in dentistry, and it wasn't in dentistry, it was medicine, and it was a problem. And so the trickle down effect, as well as the show of 60 Minutes years ago, where dentists putting patients in papoose boots and doing multiple quadrants of work. So this gave the thing, the whole immobilization a bad name. But basically, if we look at the broad picture, that people with developmental disabilities may need medical immobilization and protective stabilization in order to give them medical and dental care. There's no question about it. And we're not sedating, and we're not going to put under general anesthesia all these people. So what is medical immobilization, protective stabilization? It's controlling the patient's arms and legs from movement. And it's necessary to protect them from injury. It should only be used during the duration of the treatment and never used as a punishment, but it can include mechanical and manual techniques. So medical immobilization does not, when we talk about it, I mean, they have to, when they draw blood on people, when physicians have to put eye drops and injections and toothbrushing, it doesn't include that. So here's the problem, and this has been the issue that's plagued me. If the physician, a child falls off of monkey bars and is brought to the emergency room, a 2-year-old, a 3-year-old, a special needs patient, they need suturing. They're brought to the emergency room. The physician immobilizes them, sutures them up, and he's the hero. The child falls off the monkey bars and is brought to the dental office, and the dentist has to, whatever procedure he has to do, he immobilizes them, and he's a waterboarder. What's the difference? Is medically necessary medical care or dental care? Why should the physician never have an issue about immobilization? And why in dentistry is it an issue, and has it become a problem over the years that people don't want to immobilize them? How else are we going to deliver equal quality of care? So basically, the data shows that if we don't provide equal quality of care, they're going to have a higher incidence of untreated decay and a higher prevalence of periodontal disease. And they're not going to get the routine treatment that they need. So basically, if you're going to use medical immobilization and protective stabilization, you have to just tell the parent or the caregiver, why you have to need it, the type of stabilization you're going to use, and the alternatives if you can't use it. How else are you going to get equal quality of care? Again, it should only be used when absolutely necessary and always the least restrictive the form to use. But it's basically to protect the health and safety of the individual, the patient, and the staff in order to deliver quality and equal health care. You must document it. It can cause no physical injury to the patient, but it is totally an accepted practice when used appropriately. And I will argue with anybody that it is the safest alternative to sedation and general anesthesia. You have to document the duration too. Okay, so I've been following, I'm an old dog, and so I've been involved in special care dentistry for 40 years. And basically, it was never an issue. The special care dentistry came out with guidelines on the use of restraint in 1987. And it stood all these years, okay? Here's the abstract. And I'll share the PowerPoint. Paul will have, and the group will have the PowerPoint to give to people if they want it. But here's the abstract that was presented in 1987. It basically says that if a dentist needs to immobilize the patient to perform equal quality of care, then it's not an issue. And then basically what happened, and this has been disastrous, and the reason why I even found out about it, because I had been practicing my whole career, but I got involved in there was a lawsuits against a large dental service group, and a lawyer, basically because of these ridiculous guidelines of the American Academy of Pediatric Dentistry, lawyers, it's an open ticket. It's become an open ticket to sue a dentist because the use of immobilization, according to the pediatric guidelines, it's a loss of dignity. Explain loss of dignity to a 2-year-old who poops in his diapers all the time, but a loss of dignity, and it can cause the risks. Listen to this: that it can cause potential serious consequences, such as physical and psychological harm. And so they basically have made it so that the pediatric dentists are the only ones that can use medical immobilization because they call it an advanced behavioral technique. Can you believe putting somebody using wrist restraints or using leg restraints, leg immobilization or Velcro, that it's an advanced behavioral technique, and that only trained pediatric dentists or AGD or GPR people can use it as an advanced behavioral technique. And this has been the biggest nightmare for us in the trenches and all the trench warriors. So basically, those pediatric guidelines, and I have to tell you that when I became aware of those pediatric Academy of Pediatric Guidelines, I challenged the scientific committee that came up with those guidelines. I challenged them to show me the literature and evidence-based why they came out with those ridiculous guidelines. And their answer was, that they care about the children, and they wanted to prevent corporate dentistry from immobilizing kids and doing multiple quadrants at once. So I said, you've destroyed this for the whole field. It's become a huge problem. And I hired somebody. Actually, I hired Jessica to the board, who's a prominent pediatric dentist, a representative of the Academy in Special Needs. She did a 6-month literature review on the use of papoose boards, immobilization, cross-referencing psychiatric, sociology, public health, everything. Not one article in the literature stating that the use of medical immobilization caused any psychological harm or loss of dignity. My own grandson was 2 years old. He dove off a couch. I needed to do endo on his 2 primary central incisors. I put him in the papoose board, did the endo. that night, he didn't even know that anything had been done I went over to see him how he done. So there's nothing in the literature. So I went to the American Academy of Developmental Medicine and Dentistry, and I said, guys, this is a huge problem in dentistry. And they looked at me and they said, what are you talking about? In medicine, it's not a problem. Why should you have a problem? If you need to do medically necessary dental care, and I can hold somebody down and look in their ears or look in their throat or pull something out of their nose. If we can immobilize it, we don't even think about it. We just do it. Why are you having this trouble? But they said, we understand. And so we will give you guidelines. So if you go to the aadmd.org, you can see that the American Academy of Developmental Medicine, this was developed by physicians and dentists, okay? Developed by physicians and dentists, and these are the guidelines that are published, that are out there, that can protect you if there's any issue of why you had to use medical immobilization or stabilization to do what you need to have done. And the people who don't know what they're talking about have thrown this out to me. Oh, you're causing toxic stress to the child. That's not toxic stress. There's an association of toxic stress. Toxic stress is what happens when you don't do the treatment and these children walk around with pain and with problems. That's toxic stress. Toxic stress is not somebody immobilizing somebody for 1, 2, or 3 appointments to get all the work done. There's so much misinformation, but like I said, I wanted to talk about it because it is the elephant in the room all the time. And I realized that there are cultural things involved and it's difficult to do it, but the answer is not sedation and immobilization. And it's been my job to track all these accidents that have happened and the deaths in dental offices. And the thing is that you can't argue with the oral surgeon. I can't argue with everybody else. But basically, I can tell you that you're not, if all these accidents that happen in dental offices from sedation and general anesthesia, that you're not dead until you're pronounced dead in an emergency room in a hospital. So people have accidents in their office, but they're not office deaths. The brain damage is not in the office. So there are no data that exists that can prove this point. But basically, so let's look at some of the medical immobilization, protective stabilization techniques that we use. So physically, here's a little boy that was a patient at Children's Hospital in Boston, and they said he could only be treated in general anesthesia. Mother refused to have it done. He had cerebral palsy. I mean, he's a perfect patient. Why can't you just use mother holding? So I was a big fan, and I said, I think the secret of my success and mentally for my own use was I did not have patients in the operatory with me. But certainly with patients with special needs, with uncontrolled seizure disorders, with respiratory problems, with dysphagia, it's certainly advantageous to have the parents in the office too. So here's just physical immobilization, parents just holding his hands, involuntary movements of cerebral palsy. I don't want him to grab me. I recently was asked to be an expert witness in a case of a neurotypical child who whipped his, the dentist was working on him and he did not use, he wasn't a pediatric dentist, general dentist, did not have a rubber dam, child whipped his head. The 330 burr went across the child's whole face. He needed plastic surgery. But anyway, the use of a rubber dam is so important and just protecting the face and protecting the child. So here, physical, simplest form of medical immobilization, parents just holding it. Small children can sit on the parent's lap. Sometimes the group home can assist. In terms of COVID now, it's a problem with, a lot of these patients with special needs because multiple people are needed to provide the medical immobilization for you. I realize it's a problem today, but simply the staff can be held. Multiple staff before COVID, there's multiple staff using and helping us work on the patients just to prevent the involuntary movements. A lot of these patients from group homes or their brothers or sisters, they're confident, they know that, in whatever functioning they have and whatever severity it is, they can recognize the people that take care of them every day, that protect them, that take them to the doctor visits, take them care of the physician visits, dentist visits. They know that they feed them in the morning, they get them, they bathe them, they shower them. they know that they're not going to allow anything bad to happen with them. So it's security to have them. If you're not going to use an immobilization device, this is the person who's with them can hold the hand. They can put their sit on the patient's knees with their weight off them on the floor. The knees immobilize the lower part of the body, holding the hand so that I can do the work. Again, sometimes these are two sisters that are actually immobilizing their brother because they're both nurses and they know the need for him to have dental care. Again, more group home people. And this is the most ultimate form of physical immobilization. This is called the total body wrap. And this is the parent helping us by just laying on top of her son and helping us to provide the care. Okay, stabilization devices. You can use simple pillow stabilization for children with severe neuromuscular impairment. Small pillow behind the parents, beside the patient's head, help just stabilize them. This is the reason why I showed this slide. There was a hygienist that got into trouble for using, this is a patient with cerebral palsy who's drooling, and she has wears a bib. And in one of the facilities, a hygienist used the bib to stabilize the face because of the drooling and because of her face was so wet. And she was reported by the staff for using an immobilization device, the bib, without authorization. And so that brings me down to the barrier to care. Remember, I talked about a slide that said fear of accusation. How ridiculous is that? Anyway, using the bib as a immobilization device to hold the head still. A lot of children, again, with severe neuromuscular can use the car seat. Just bring in the car seat, and child can put the car seat on you can put the car seat on the dental chair. A simple beanbag, an inexpensive beanbag, can be used for, again, children with severe neuromuscular disabilities. You can use Velcro for the arms, Velcro for the legs, so you can use a head, a leg, or an arm immobilization. This is called the vacuum pack. It's a big giant beanbag, and you suck the air out, and it becomes a concrete block, and it won't impinge upon the patient, but it can stabilize them to the point that you can work on them in that position, a vacuum pack. We're doing a lot of, I'm teaching at Buffalo and a couple of other dental schools as well as BU. And my friends that are doing a lot of special patient care are using weighted blankets. You know, kids with autism now are sleeping in weighted blankets. You can get them anywhere. So in one of my go-to clinics in the country, they're finding tremendous success. They like this summerfly.com. This is a weighted blanket. It's easy to clean. This is what they've tried many different kinds of weighted blankets, but this is what they're using. And you'd be surprised in taking radiographs and doing operative and doing recall visits. Use of a weighted blanket. These kids they sleep with them at home. They're used to it. You'd be surprised at what you can get away with a weighted blanket instead of using a more of a papoose board. This is called the PD wrap. It has separate Velcro arm restraints. And you know something, in all my years of practice, when I've approached the parent and said, you know what, general anesthesia presents with a risk. I definitely don't want to sedate them in the office because of the they're on, a lot of my patients are on 10, 12, 15 different drugs. Am I going to start introducing another drug to them to sedate? And the other thing, the big thing is there is no drug that's been made for dental sedation. So what we do is we use drugs that are off-label. And so if, God forbid, any accidents happen, you've used a drug to sedate somebody that was not made to sedate them for dental visits. So there's no legal stance for you to stand on if you have an untoward reaction to any oral sedation, or for that matter, IV or IM sedation that you're using. So there's nothing, every time I presented to the parent that if I can do this without sedation, but I'm going to have to medically immobilize them, from my experience. And if they didn't want to do it, I would refer them somewhere else, because I was not going to go into the operating room and put somebody risk versus benefit. And I worked in a great hospital. It was all Mass General. I was part of the Mass General system. So I had the availability of great physician. But if I could treat them safely with immobilization, I was going to do it. So there's a PD wrap, and that slide is dark, but it's the use of a papoose board, and I'll have another slide of it. There's a company in New Hampshire in the USA called the Specialized Care Company. They make dental products for people with disabilities. They make the best mouth prop I've ever seen and ever used. They make, go to their website. I have no interest in the company, but they're wonderful people that own it. They'll be happy to discuss things with you, but they make dental products for people with disabilities. This is a pillow that basically a chair that you put over the chair, and then you can put the papoose board over it, or the child could just sit in it themselves. You can see it's very comfortable. They make every kind of mouth prop. They make a 3-headed toothbrush. There you see it helps stabilizes any of the papoose boards or that you can use for it. And there's something called the Joey board now. A Specialized Care Company has their own immobilization board, as well as the old papoose board from the generic papoose board. And so there's just some slides of working on adults with disabilities. Again, I did practice without parents in the operatory, but again, with seizure disorders, uncontrolled seizure disorders, and other problems, there's certainly the parents. I have no objection to the parents, and found it, very useful to have them with me. So I want to end the lecture with this case because it kind of says it all. And basically, I was presented with a patient who's was about 6'4", 300 pounds, 21 years old, with autism, came in with his dad, who's also a big guy. And when I went to examine the patient, he actually almost knocked me out. He pushed me away. And really, I could not, he was not cooperative at all, and actually pretty combative. And so my office has a SWAT team, we call it. And I got a metal finger, and I got a quick look at his mouth. And I saw that he needed his wisdom teeth out, and he needed third molars out, and he needed a bunch of restorative dentistry. And the father said to me, "You don't have enough guards, and it's going to take an army to get him in the hospital. You can't have enough security guards to get my son in the hospital." And so, because of the nature of having the third molars to be removed and working with an oral surgeon, and myself doing a significant amount of restorative dentistry, I knew I had to treat him in the hospital. And so I went to my anesthesia department, and I said, "Listen, there's no way we're going to get this patient in the hospital. How are we going to do it?" And because they're compassionate, caring physicians, and they respected the work that I did, we said, okay. So we actually put the patient to sleep in the parking lot. And so basically, I had anesthesia, had 2 crash teams in the parking lot. The patient came in a van from the group home, and his dad, he's wearing a seat belt, and his dad is talking to him. You could see in the upper right, he's looking at his iPad, and his dad is playing games with him. And the physician, the anesthesiologist, opened the van in the back and crawled in with a ketamine syringe in his mouth, and basically stabbed him from behind in his shoulder with the shot of ketamine to paralyze him. Because of his size, he was huge. We had to give him a second shot of ketamine. We rolled him onto a stretcher. The anesthesia team, brought him up into the hospital in the operating room, and we did the wisdom teeth. We did his surgery, his restorative dentistry, and discharged him as soon as we can before he ripped the IV out in the recovery room. But it shows you that a dental team, the respect that working with physicians. So we put this patient to sleep without a physician listening to his heart, without any examination, just from the seat of our pants, because we're committed to delivering quality care to our patients. And the medical staff respected the work and the importance of oral health in the total health of the patient. And we were able to treat patients like this. So here he is we rolled him over on the stretcher, took him right into the OR and did his work. And it just shows that, with out of the box thinking. And that's one of the things that I really want to impress to you, that, every patient with special needs is different. Just like they say, every child with autism, if you've seen one child with autism, you've seen one child with autism. So many of our special needs patients are the same way. And so delivering the optimal best care for them is our challenge every day. So I want to thank everybody for listening in. I want to thank everybody for inviting me to speak. I want to look forward to working with you in the work that we do in Special Olympics and being an integral part. So many, like I said, I've had students in the past, and we have a great Special Olympic program, and I look forward to working with you all in the future. Let this not be the end of our work on patients with special needs. Thank you, everybody.
Thank you very much, Dr. Perlman, for that very wonderful, informative lecture, and your admirable work that you've done to these patients for over the past years. Your long list of awards truly speaks for itself. And I'd like to thank you also for enlightening us about using protective immobilization. Actually, in my practice also, over the last maybe 2 years, I have minimized the use of IMIV sedation on patients, because I have seen that, because there's a lot of patients who are, quite reluctant right now in having sedation. And of course, these patients still need dental care. And I'm so happy and glad that I'm able to do, oral rehabilitation with them using protective immobilization. And even my son, he doesn't even remember that I, put him on a papoose board when he was 2 years old. So thank you once again. So I would like to remind everybody to please post your question in the chat box. Okay. So we have a question here. So how do you become a volunteer dentist for Special Olympics? Okay, we cannot hear Dr.
Okay.
Okay, there you go. All right. Okay. Thank you.
Hi, everybody. Thanks for tuning in, and thanks for listening. And it's great to see my old students, and look forward to working with you guys. So we have the way we work is we have a regional health. We support somebody in the region, because we need to do grassroots. We need the regional support. So we have a person in charge of health for the Philippines. And I will send you the society, the name of the person, and we can begin the dialogue there.
Okay.
Okay, so we have a full-time employee in the region that just works on health. So now, of course, with COVID, we're not doing the face-to-face, although we have some virtual programming. But I will link you guys up with the person. I've already put her in charge. She was supposed to be on this video, on the lecture today. But I'll give you the name, and we can begin the ball rolling through that. Okay?
Okay. Thank you, Doctor. Yeah, I know that you're trying to do a program with Dr. Paula Baya and Dr. Eric Hernandez to be able to start up something with the Special Olympics. Because I know we have it here in the Philippines. We do have Special Olympics in the Philippines, but however, it's not very much recognized. So I have a question. Yeah. So I have a question, because silver diamond fluoride or the saccharide is becoming is gaining quite a good popularity here in the Philippines. So do you use this for special patients? I know that it has already been approved in the United States.
Yeah, people swear that. So I retired 2 years ago, before the silver diamond really got. We were using it, and actually, we do use it in some of the events, depending on, because we had the year before COVID, we had 300 Special Smiles events in over 100 countries. And they were applying it. As you know, there's no danger in the application. You just have to inform the parent that it may turn the tooth black or something like that. But the safety is well documented, and we're talking about implementing it just like we have the mouth guard program, just like we had the fluoride varnish program. Silvadiamine from people, they say it's kind of like a magic bullet for us in use of delaying care.
Okay, thank you. We have another question here. Does it need specialty to become a member of that program, Special Olympics?
No. You mean for an athlete to participate in Special Olympics, there has to be an underlying diagnosis of an intellectual disability. That's the difference. There are 3 organizations in the world that are allowed to use the word Olympics. Olympics, Paralympics, which is people that just have physical disabilities. But to participate in Special Olympics, you have to have an underlying diagnosis of an intellectual disability.
Okay. So with the Paralympics, these are the people with physical disabilities. But for Special Olympics, it's more for patients with mental disabilities.
Yes, but there's so many co-morbidities. So many people with intellectual disabilities also have physical disabilities. Cerebral palsy, Down syndrome, all the other things. So, but there's no Special Olympics is never not include somebody because of the level of functioning. If somebody is a quadriplegic and the only thing they can do is move their hand, they will develop a sport or something that they can participate in. Nobody is excluded because of the severity of their disability.
Okay. And then also I have a question with regards to, giving alternative medicine for these patients, because there are some alternative doctors who gives them alternative medication. So I don't know what is the stand of, medical practitioners in the United States, like for example, the CBD oil and
Oh yeah, actually, it's interesting that you brought that up. Kids with autism, they are using a lot of CBD products on them. I know a lot of people a lot of dental professionals and medical professionals that are using it on their own children.
Okay. There's another question here. Great talk, Dr. Perlman. Just to clarify, there are developmental disabilities without associated intellectual disability. Are they excluded? For example,
no, you mean
For example, these are children with autism, but they don't have intellectual disability.
Like the autism that are Asperger's or high functioning autism.
Yes.
Yeah. They can participate. And also we have the fastest growing movement within Special Olympics is called unified sports, which is the team would have half people with a it's the best thing that we've done to break down the barriers for people with intellectual disabilities. So a team like a basketball team or a volleyball team or a softball team, they would half are neurotypical people and the other half is special needs, all working together, all playing together on the same team. It's a wonderful program. So they can participate in the unified sport. I can't tell, sometimes at the events, I can't tell if somebody's really an athlete with Special Olympics because they're on the spectrum disorder and they're very, we're doing a lot of work. There's a amazing person who has a website called differentbrains.com. And he specializes in he's an actually very interesting guy. He's an orthopedic surgeon who went into this field full time. And it's differentbrains.com. And it's he celebrates neurodiversity. And basically it's every brain is like a snowflake. There's no two brains alike. And he employs all people with autism. And he's got amazing interviews. Everything is free. We're doing a lot of work with him in Special Olympics. So differentbrains.com. So yeah, we embrace every form of neurodiversity.
Okay. How is Special Olympics keeping itself financially sustainable?
You mean through the COVID? So basically, when I started with nothing, and I just had a pilot program and went to Boston University where we founded it, it's been an interesting ride. So right now, just in in health, we get roughly $14-15 million from the CDC in the United States. We have a private philanthropist who's giving us $5 million a year. That's about $20 million. And then we raise about another 10 million through Lions International. Lions, which is a fabulous group internationally, they give us roughly $2 million a year for the Vision program. So, and then we have corporate sponsors. Like when we do events in the Philippines, we will be sponsored. Colgate is one of our, Colgate is a global sponsor. So we'll work with Colgate. And do you have Henry Schein in the Philippines?
No, we don't.
Okay, well, whatever dental supply company there is, we will find a way to work with them because there's never a charge to the athlete. And when we do the program in the Philippines, we will be responsible to raise the money. We would be happy to work with your society to go to a corporate sponsor, but there's never a charge to the athlete. They don't pay for the uniform. They don't pay for anything. It's a strictly volunteer-based organization. So to answer that question, in health, we raise about $30 million a year.
Wow.
Just in health, just in health.
Oh, okay. I hope we can do the same also for the Philippines. So there's another question with regards to the use of nitrous oxide here. So how often do you use nitrous oxide with in patients with special needs?
So I trained because, I trained at BU and we used to, trained in nitrous oxide, but we found that we really didn't need it. That, maybe I'm really an old dog and old school, but I found that TVs were my nitrous oxide. The children can really, really zone out with TVs. And so I know, I brought up the example in my lecture. I told you that a friend of mine, a general dentist who actually specialized in special patient care, didn't really got burnt out in practice and wanted to work for an insurance company. And she calls me with these horrific stories all the time. And she said she actually went into a pediatric lab. Every single patient had nitrous. I mean, I don't get it, but definitely nitrous has its place. It became, my partner and I found that we didn't really need it. A lot of times kids with special needs don't like the mask coming at them. They have enough problems. Certainly now with all the PPEs that everybody's doing it, let alone coming and putting a mask on the face and getting a good seal. So I am not an expert in nitrous oxide. Like I said, we used to use it and then we got away from it. I think we all, if you evaluate your success and the best thing about at night, we all have to go home and live with ourselves and what we do during our days, right? And how we treat our patients and reflect how we treat our patients. And I just felt that, it was something, I think maybe the dentist should use the nitrous oxide at themselves to calm them down rather than the patients. I think if you just thought, kids, I never, it's interesting practice. You guys, a lot of you probably practiced in an open bay. So I would constantly get the question. It's like, oh, one kid starts crying, they all start crying. But I think it's the opposite. I think most kids tend to be good patients. And then the other kids wind up, because of peer pressure, they wind up better patients. We're working on things. I'm working actually with Septanon on a better tasting local anesthesia. We're doing everything that we can to make the dental experience. Don't you guys feel that as a pediatric dentist, your job is to train patients to be good patients when they're adults, and that dentistry doesn't have to be a terrible experience? I don't think it requires any skill to give a child a shot of Versed, or just slap a nitrous mask on them before they even do anything.
Yes, I certainly agree, doctor. There was this general dentist who told me once that you cannot be called a pediatric dentist because you just keep sedating patients. So, that kind of stuck into my head, and then, just started to really learn how to be patient with my patients. So whether, music, crying has already become a music to my ears. Okay, so we have another
Yeah,
question.
I mean, a lot of times, you can't judge the most. I can't even tell you how many kids I got referred to me to do in the hospital, adults do in the hospital. And it's like, it's interesting. We all know the Frankel, the Frankel behavior scale, right? That's the classic thing that everybody uses, right? So at one point, I thought that maybe in special needs that we should have a scale where the dentist would be able to rank somebody's behavior or something. And it turns out that the more I thought about it, and I trained under Spencer Frankel, you know that, he was the dean when you were there, right? So I thought about it and I said, the worst thing we want is to prejudge a patient, because how do we know that patient that they come in or they were terrible for 2 or 3 dentists and they were thrown out of other dental office, but how do we know that patient, maybe it was a male and he only likes females. Maybe he had a fight with his caretaker or his mother the morning of. Maybe he didn't get any sleep the night before. Maybe he was constipated that morning. Maybe he didn't get his medications on the regular time. So there are so many with patients with special needs, there are so many variables. You don't want anything to cloud your judgment, especially many of you in your society, I'm sure get patients referred to you because the general dentist doesn't want them. Their behavior was awful. They couldn't wait to get rid of them to send them to you. And you're saying, oh, this kid's going to be terrible. He's thrown out of 3 offices. But in reality, when you approach it's just that you're in you're all practicing in an atmosphere of more nurturing than you know what I mean? So the point is that there's no scale that should be done. Everybody should take every visit as an individual. It's like with immobilization. The first time that you may have to get your SWAT team to grab them, put them in the dental chair, because they're never going to get in the chair. You have to drag them, put them in the chair. And maybe you need to immobilize them. But you know what? At the end of the visit, you start to do the exam, you take off the arm. About another minute or 2, take off the legs. And then the child is just sitting in the board. And next time those kids with autism, they go right in and they want the papoose board because they like the feeling of immobilization. And like I said, we all take our babies home from the hospital. They're swaddled. We hold our dolls. If we love somebody, we hold them close to us. People are reporting tremendous success with weighted blankets. Okay.
Yes, thank you. Okay. Was there any guidelines or protocol in treating special needs patients prior to sedation or general anesthesia in this time of pandemic? Thank you for this inspiring lecture.
Oh, you're welcome. Thank you. Well, the whole thing about sedation, it's interesting. So NYU had a meeting this week, and they asked me to talk about how is the virus affected the pediatric practice. So number one, the biggest problems, dentists in the United States are giving up Medicaid. A lot of people were on the fence, but now with the additional cost of PPE, they don't want to treat the Medicaid patients. So we're having a real crisis in who's going to treat the poor kids, okay? Number one. And number two, this issue of, the hospital operating rooms. Dentists are not getting any time in the U.S. There's no time for pediatric because the physicians, they're backed up on all this, biopsies and all their scopes and all their procedures. So they have to start thinking out of the box, like, how am I going to get this done? There was an interesting chat last week that it absolutely flipped me out that said, that they're afraid, pediatric dentists are afraid to treat kids that are crying now. Because when the kids cry, the aerosol gets sprayed, right? So they're actually talking about putting children in that are crying into the operating room without an exam. How unconscious is that you put somebody in an operating room and find out they don't even need anything? We're all preaching, one pay. You're doing a dental home. We say that children with special needs need a medical home by year 1, and the same thing for a dental home, right? you know, what 1-year-old and 2-year-old is not going to cry when you do the exam?
Yeah.
So the coronavirus is definitely having a negative effect. And certainly with these behavioral issues, you know, you may need 2 people from the group home, you may need the parents, you may need 3 people to help immobilize them, to help you get going. And this isn't happening now. So as bad of access to care was for patients with special needs, the COVID has made it much worse.
Yeah, I certainly agree. Even for my pediatric patients, I like what I said earlier. I've minimized doing IV sedation in my private practice, but apparently right now with with the COVID happening, a lot of the parents doesn't want to bring back their children to the clinic anymore, so they prefer to have to do everything in one go.
Right.
So there's another question here. What advice can you give to general dentists who want to start treating this group of pediatric patients?
Okay, so the best advice, I have a book that's out that's used in a lot of dental schools, but don't buy it. It's expensive and it's not worth it, because the only way you learn is to do it. So there's so many times that you're going to say to yourself, there's no way I'm going to get this done, but just try it. The more you do as a general dentist, you don't need any special skills. The more, yes, you need some tools. You may need some mouth props. You may need a way of opening the uncooperative patient's mouth. There's many different things. Like I said, the website, there's a specialized care company. They ship all over the world. They make dental products for people with ID. As a general dentist, all you may need is just a good mouth prop, because somebody's not cooperative, or they have cerebral palsy and they have difficulty. So they make amazing products. Go on their website. So a specialized care company, and look at AADMD for policy and guidelines, okay? Because we're there to support, these, like I said, my job in Special Olympics is to reduce the barriers to care for patients with special needs. Basically, my job is to improve access to care for patients with special needs and to educate dental professionals about how to treat this population. It's not that complicated. In the U.S. now, we're faced with one out of 54 births have a child with autism. It's not diagnosed till the age of maybe 2, 3, or 4. So you're all going to be seeing these patients. All general dentists are going to be seeing these patients in the practice. And like they said, if you've seen one patient with autism, you've seen one patient with autism. They're all different. Just just practice, try and practice painless dentistry, and you can do it. You can shake the lip, use topical. There's some great topicals out. But it just takes maybe it takes a few more minutes to do it, but it's well worth it. Like I said, with my examples in the practice, I think it's very rewarding. And you'll all go home at the end of the day feeling good about yourself, that you broke through that sensory divide that holds hostage people with special needs.
So do you use a rubber dam, and do you use what are your treatment protocols? Do you do pulpotomy, stainless steel crowns for the younger kids?
No, there's no difference. Every parent, speaking at the general dentist, that every parent that brings their children or adults to you expects that you deliver equal quality of care, right? That's the bottom line, is that we're not going to compromise our standards. We're going to do equal quality of care. So, we're trained, pediatric dentistry, we're trained to use rubber dam. Rubber dam is important because kids move, they grab your hands. There's a lot of accidents that happen that I see, but you can get a rubber dam on anything. I mean, you can put a rubber dam on and do a stainless steel crown on a second primary molar too. Just clamp. I used 2 clamps my whole career, 2 8Ts and 8 As. And you can get an 8A on a newly erupted first or second molar by just, those clamps. You can just give, and you can give a good palatal. Make sure you give a palatal for the, the upper molars and the lower. You learn to see the better you get. We always have to worry, are kids going to bite their lips? Kids with special needs. we have to worry about them lip biting after local anesthesia, right? Or just like the little children, small children, 2, 3, 4, 5, 6, 12-year-olds can bite their lips too. So always using, the best piece of advice I can give that I've, as a teacher of pediatric dentistry for 40 years, 45 years, children and patients with special needs don't understand shades of gray. You could say to an adult patient, this is only going to hurt for a second. It's not worth being numb. But with a child with special needs patient, don't ever enter into the gray area. Either it hurts, either it kills them, or they don't feel it at all. So give the local anesthetic, because once they start the crying and once you lose them, you've lost them for the visit. So don't get into the shade of gray. They don't understand that.
Okay. Thank you, Doctor. We have another question here from our speaker last Friday. He is a developmental behavioral pediatrician, Dr. John Harold Sia. I wonder how an MD can be involved in Special Olympics, given that we usually see special needs before they are diagnosed with their developmental disability.
We have a program in Special Olympics for physicians. It's called MedFest. And what they do is they clear the parents, they clear the athletes for competition. So there's definitely a home for us, for physicians in Special Olympics in the program. Yeah, they can, we have a program called Health Promotion. And just see, I'm working on women's health, sleep apnea. Sleep apnea is a huge problem. Sleep is a huge problem. Kids with autism don't sleep because they have a problem sleeping, and they keep their parents up, they keep their brothers and sisters up. So that's one issue. And then people with Down syndrome have obstructive sleep apnea. So we're getting into women's health, we're getting into sleep, we're doing all that. So there's definitely a home for physicians.
So you mean this is counseling the parents, yeah, about their health in general? A follow-up question from Dr. Sia.
Yeah, well, MedFest, like I said, the athletes, to participate in Special Olympics, you need to be cleared by your physician, right, for participation, because we want to make sure they don't have heart problems. So to clear for the competition. So we have a program that physicians can sign up for called MedFest. And then we bring the athletes in for the physicals, and the physicians can clear and do it's a great program with great physicians that run into it. And if the doctor contacts me, I will hook him up with the program. We have, like I said, we have speech and language people. We have, we're doing a tremendous amount of work with occupational therapists now. Actually, I'll keep, through this society, I can keep you informed. There's actually an amazing video that was made by the University of Buffalo. The occupational therapy department works in conjunction with the pediatric dental department, and they just came out with this kind of a desensitization program that I'll be happy to share with you. I think you're going to love it. It's going to be on the AADMD website very soon. Paul, you can communicate me with love. The AADMD website is a wealth of information. And, if you're a faculty, if any faculty member, it's a free, you get free subscription to AADMD. And the students, all your students get free membership. Actually, there's another thing I could do. There's a Bible for parents and caregivers. It's a magazine called Exceptional Parent Magazine. There's an article. It's amazing. It's the Bible for parents and caregivers with people with intellectual disabilities. Everybody that's on the call tonight, I offer a free subscription to it. It's all lowercase, subscribe.ep-mag, M-A-G. You're going to love the magazine. It comes out every month, and it's a free online subscription to all the society members.
Okay, and we have our last comment from Dr. Lisa Centeno. Thank you, Dr. Perlman, for the wealth of information that you're sharing with us. I want to share that I sometimes use the lead apron as weight blankets for patients with autism.
Exactly. Good point. Thank you for bringing that up.
Yes. So I'd like to call thank you so much, Dr. Perlman, for giving us such a wonderful insight on, how to deal with patients with disabilities and for doing so much for them. And I'd like to call Dr. Paul Abaya to give us, to comment.
Hi, Dr. Steve.
Hey, Paul, how are you? Good to see you.
Thank you so much for gracing this occasion, and I totally support what you did say about how to start a practice by seeing these kids, no?
Yes.
And it brought a lot of nice memories when I was a resident at Rose F. Kennedy. So we would run after these kids with ketamine just to roll them back into the clinic. And it's just that first step that you have to take, and the rest will just follow naturally. So I would always encourage all the general dentists who are here tonight to really take that first step, and PPDSI, our society, will be more than happy to help them out, because we need a lot of help though.
Absolutely.
Thank you, Dr. Steve.
You're welcome. Thanks everybody for listening. I look forward to working with all of you. There's nobody that's on this call that cannot work with us together.
Okay, thank you so much, Dr. Perlman. I hope you don't mind spelling out again or even saying the website that you mentioned earlier, so that somebody can write it down on our chat page and take note of that.
For the EP magazine?
Yes.
Okay, so let me see. Is that good?
Okay, let me take a picture. All right, okay. I hope you guys took a picture of this. Yes.
I could send you the link, Paul. So
okay,
I think,
no problem.
I think you guys are going to love the magazine, and if anybody wants to write I'm on the editorial board. So if anybody wants to write an article, I certainly would welcome it. Check out the new issue. It's really good.
Thanks, Dr. Steve.
Okay, so we don't have any more questions. So that wraps up our string of 4 lectures. And thank you very much, Dr. Steve Perlman, for this wonderful lecture. And we would like to present this certificate of appreciation. The Philippine Pediatric Dental Society Incorporated and the University of the Philippines Manila College of Dentistry presents a certificate of appreciation to Dr. Stephen Perlman in grateful recognition of his participation as guest lecturer for sharing his expertise and knowledge through the topic Special Olympics, Special Smiles Program, Caring for People with Intellectual and Developmental Disabilities, given this 28th day of September 2020 during the PPDSI String of Pearls webinar series. Signed, Dr. Paul Plaridel Aguinaldo Abayo Jr., President, PPDSI 2019 to 2021. Dean of the UP College of Dentistry, Dr. Danilo Magtanong. Awards Committee Chair of PPDSI, Dr. Rowena Cornejo Castro. And the Coordinator for Continuing Education of the UP College of Dentistry, Dr. Jean Arevalo. And lastly, our Scientific Committee Chair of PPDSI, Dr. Hazel Marie Talas Sunico.
I am deeply honored and look forward to letting this not be the end. I'd love to come and see everybody in person, and I look forward to working with everybody.
Likewise. Thank you so much, Dr. Steve.
You're welcome.